Thank you so much. I appreciate that. Yeah, thank you everybody for making the time to watch and listen to this. And yes, thank you so much to Zomedica for sponsoring it. So a little bit about me for those who don't already know. I graduated from Cornell University in 2006. I had a one-year general internship at Angel Animal Medical Center in Boston, followed by two one-year surgical internships at Long Island Veterinary Specialists, then a surgical residency, small animal surgery at Long Island Veterinary Specialists. After that, I left New York, joined the West Coast of the US, and became part of a specialty hospital here in Las Vegas, Nevada. After that, I spent about a year in Silicon Valley managing three facilities there on call 24/7 for about a year. And then from there, transitioned over to LA, where I was part owner of a hospital. We converted that hospital from overnight to 24/7 ER and multi-specialty. And again, I was on call 24/7 for the better half of about a year and a half being there. And then the end of 2019, I launched Vet Triage, the virtual platform. So we're going to go over a whole bunch of stuff here. The talk is intended to be practical, clinical, useful for you. I do have more detailed proceedings if desired that go into way more detail, mostly on the academic and literature side. But this is meant to be a more clinical and purposeful talk. So we'll define some of the parameters that outline brachycephalic airway syndrome. We'll talk about the pathophysiology, the associated GI disease, clinical signs, all the diagnostics that you may want to consider for working these dogs up or for referral, medical management, surgery, monitoring post-op, any complications in the outcome prognosis. And that should provide a pretty good overview for this very common condition. So by definition, it is a multifaceted syndrome for these dogs. The list here is by no means the entire list, but the most common things that we're going to deal with. And there's a variety of other abnormalities with these dogs as well that are maybe less common or perhaps less commonly investigated. Elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, laryngeal collapse. And a helpful way of thinking about these conditions, especially when you're talking to a pet owner, is to define them perhaps as primary and secondary, primary being the initial insult, secondary being a secondary cause of the primary conditions, or probably more useful to talk about them in terms of what we can repair and what we can't repair. And pet owners tend to have a better understanding of this when you categorize the portions of this disease in that manner. Here are the repairable things, here are the irreparable ones. And the irreparable things may get better after you fix what's fixable, or they may not, depending on the situation and what you're talking about. So pet owners have a better grasp of it. I have a YouTube channel, and on that channel, I do have a video describing this as well. If you find that useful, you can always share it with your clientele. So we'll kind of go through the pathophysiology here of this complex condition. There is sort of a continuum with it. The vast majority of these dogs, it begins with stenotic nares. That's the beginning part. And if you look at that center picture there, you can see what we are very commonly used to seeing, stenotic nares. It increases the airway pressure in the nasal cavity, nasopharynx, and it just creates downstream effects, larynx, palate, down to the lower airway. And so it all starts there. So theoretically, that primary condition of stenotic nares, if repaired, would probably reduce or eliminate the risk of developing other conditions associated with brachycephalic airway syndrome. So over time, as that increased airway resistance occurs because of stenotic nares, the palate becomes longer and thicker, and it starts to cause an obstruction, a dynamic obstruction of the upper airway. And that then adds to the increase in airway resistance for these dogs, which then causes increased pressure of the laryngeal area. And that's when you end up with everted tonsils, everted saccules, over time, laryngeal collapse. Now, these dogs are also sometimes, especially English bulldogs, born with hypoplastic trachea, a lower airway condition. And that can be pronounced even more so when you have all these upper airway changes. A hypoplastic trachea is a smaller than normal tracheal diameter, and it's going to compromise lower airway. You can get bronchiolar collapse from there. Secondarily to all those pulmonary changes, you're going to end up with possibly cardiac changes. So in that radiograph, you can see that the trachea, it's a lateral plane radiograph of the thorax and cervical region, and you see that trachea is just a bit more narrow than you'd like to see. And whether that's actually a hypoplastic trachea which is a condition they're born with in these dogs, with the primary condition, or whether there's redundant tracheal tissue on the dorsal aspect of that trachea, causing it to be narrow. It's hard to say on radiographs. You're not going to know that because of all the soft tissue superimposition. But the point is to make sure that when you are working these dogs up, one of the most commonly performed diagnostics will be radiographs. And it not only helps you with searching for bronchopneumonia, metastatic disease in older dogs, congestive heart failure, any other reason to have respiratory distress, it also allows you to characterize the syndrome more thoroughly for these pet owners. So you will only notice hypoplastic trachea on radiographs. There's a computer tomography scan, so a CAT scan there showing a sagittal view of a normal skull-shaped dog, and then B, of a brachycephalic. You can see it's comparing the nasal cavity from one breed to the other. It's a dramatic difference, obviously, with these dogs. If you look at the picture there of the pug versus the boxer, you can see there's different levels of brachycephalic breeds, right? Even pit bulls are considered brachycephalic, Cavalier King Charles Spaniels. Then you have the extreme ones like the pugs, where they have just a sloped face. And so, we're all used to this, but just to show you, there is a spectrum of this disease. And then the scoping pictures there show in A, normal nasal cavity, and then B, there's caudal aberrations of the turbinates there, and so that also adds in brachycephalic dogs, adds to the obstructive pattern with them. The reason why I'm bringing this up is because you can see that diagnostically you can get as fairly routine or simple as plain radiographs all the way to CAT scans and scoping, depending on the case, the pet owner, what specialty medicine you have available to you, what fancy toys you have at your clinic. So all that can kind of play a role in trying to stage these dogs. We'll go into more details in a bit. Gastrointestinal disease is commonly associated with brachycephalic airway syndrome. We see GI disease as a related thing, so usually secondary, or it can be a concurrent abnormality in these dogs. You can have a dog with brachycephalic airway syndrome that also has inflammatory bowel disease or something. But the association in the literature is clear, and it may affect prognosis. So it's something that you want to ask for, inquire about in the history, but also work them up for it as well, because you don't know whether or not it's related or not. If you investigate these dogs' history more thoroughly, you'll find out that the majority have some sort of chronic fluctuating GI issue in their past. Occasional regurg or vomiting, occasionally loud stomach sounds, flatulence, inappetence, and it may clue you in as to, there's something more chronic here. And then you can work them up from there. So that the lateral radiograph of the thorax with the yellow arrow, that's showing diffuse megaesophagus. The reason why you can see megaesophagus in these dogs is if they are more prone to reflux esophagitis from the stomach into the distal esophagus, that esophagitis can cause what looks like megaesophagus. So not a neurologic, not a neuromuscular disease in these dogs, but a secondary sequela of the esophagus reacting to all the inflammation from the acid reflux. So that's one thing to look out for. And of course, we are all worried about megaesophagus from the standpoint of aspiration and developing bronchopneumonia. The other radiograph, lateral abdomen, shows gastric dilatation, not volvulus, but dilatation because of aerophagia or poor gastric motility. But brachycephalic dogs are also prone to pyloric stenosis, pyloric hypertrophy. And so in that bottom picture there, the drawing, that's showing a thicker than normal pylorus. So is that gastric distension with gas from pyloric stenosis, or is it secondary to chronic aerophagia? Or is an acute aerophagia from developing bronchopneumonia, congestive heart failure, etc. So these are all things to take into account. And then the central drawing there shows us a sliding hiatal hernia, which again, very common in brachycephalics, whether it's a primary condition or secondary to chronic increase in resistance and airway pressure from brachycephalic airway syndrome. Difficult to say, but when you investigate these things, both the history and through diagnostics, you start to see that it's a multifactorial problem. We're all used to the clinical signs of this disease. They're going to be brachycephalic. They're going to have that open mouth breathing with the tongue hanging out. They're snorting. They have very loud respirations, and of course they can come in from just being stable, normal, happy puppies, all the way to respiratory collapse and shock, recumbent. Radiographs are going to be our first mode of diagnostics here. So in the skull radiograph, for example, the point there is one of those green arrows by the endotracheal tube. You can see it, the soft palate is there. So just to show you that you can visualize the soft palate on radiographs, especially when it's like that thick, meaty soft palate that are affecting these dogs. You can see it on radiographs. The central picture there is a lateral thoracic view. It's focused in on the thoracic inlet. The reason for this is because there was a study that looked at how to objectively decide whether or not a trachea is hypoplastic in a dog. And so you can use the measurements from this radiograph to calculate a ratio, and that ratio tells you whether or not you have hypoplastic trachea. Overwhelmingly, the English Bulldog is the represented breed for this condition. And then the final radiograph there, the lateral thorax, that's more zoomed out. It's the goal there is to show you that bronchopneumonia typically has a more cranioventral distribution to it. And it's important to screen these dogs for bronchopneumonia because it is a common sequela to both chronic GI disease as well as airway disease. It affects your anesthetic protocol, the risk of postoperative recovery, things like that. Sorry, 1 sec. Okay. Bear with me. Okay. So CT scan, obviously less accessible than radiographs, but is for those that want to perform a workup or the surgeon feels it's appropriate to work them up, you're looking at any other concurrent issues, maybe irreparable, but you're looking for any other concurrent issues to stage this dog effectively. So abnormalities in the nasal terminates, like we showed in that scoping view before, common issue with these dogs. Well, I shouldn't say common. It's probably common, but it's underdiagnosed because most of us, including myself as a board certified surgeon, I'm not performing CAT scans routinely unless I have some reason why I'm going to do so. But if you were to investigate, you're going to find stuff. And then that table just shows that we do have an objective measurement for abnormalities in the caudal nasal turbinates in these dogs. So if you do perform a CAT scan, you can actually grade it and determine prognosis from that. Laryngoscopy is key. That's besides radiographs, we're going to be scoping these dogs under mild sedation, so you can still watch their breathing patterns, still watch the laryngeal function while they're being sedated, but sedate enough that they actually allow you to look. Those brachycephalic dog oral cavities are very tight, and so so they need to be asleep enough, but still awake enough that you can determine arytenoid function. So the main goal with laryngoscopy, besides characterizing all the upper airway abnormalities, is to determine whether or not there's laryngeal collapse. And we do have stages of laryngeal collapse. These stages are progressive. There can be some overlap. Stage 1 is on the everted saccules. The saccules are right behind the arytenoid cartilages. And so you can see in the bottom picture there are those two bubble-like structures beyond the larynx, and those are everted saccules. That's stage 1. Stage 2 is when there's some sort of contact between the cranial portion of the arytenoid cartilage, the cuneiform process. And then stage 3 is involving not just saccules and the cuneiform process being in contact with each other, but now the carniculate process, which is the more caudal aspect of the arytenoid. So once you start getting the entire arytenoid cartilages contacting each other, that causes inflammation, swelling, edema, which then furthers the increase in airway resistance, which then progresses the laryngeal collapse further, and it just becomes this vicious cycle. So this is important when you're trying to figure out what is contributing to this dog's respiratory demise, and prognosis-wise, what can you do about it? And there's no special tools for this, by the way. You're simply using a laryngeal scope the same way you would for intubation. So this is the same thing you would use. And in fact, if you want to transition from diagnostic to surgery, let's say you're set up that way, or a surgeon is working this case up, then you would investigate the laryngeal cavity, document all of your findings, intubate them, and then get ready for surgery. The lower airway evaluation, very important with these dogs. Even though there may not be a lot you can do to repair them, you want to use them for staging purposes. So thoracic radiographs, looking for hypoplastic trachea, congestive heart failure, pleural effusion, metastatic disease, hernia, megaesophagus, etc. And then scoping, if you have access to it, to look for any other abnormalities might be present in the lower airway. The scoping portion of it, I don't routinely perform. If I suspect something a bit off with this case, then I may push for an internal medicine evaluation for a scoping. But otherwise, I want to just show you that it is an option for being more thorough with your diagnostics. So after you've diagnosed the condition, depending on how stable or unstable the patient is, we're going to be talking about medical management. Now, medical management could be used, as I said, for stabilization purpose to get ready for general anesthesia and the operating room, maximizing postoperative anesthetic recovery success. Or it could be used for those patients that either are not surgical candidates or for whatever reason, or the client does not want to pursue surgical repair of this condition. So both. And so it depends on the situation and your own experience as a doctor. But this picture, of course, is showing oxygen therapy, the different ways you can administer oxygen. Some are better than others. It all depends on what you have access to. But obviously, hypoxemia is a problem with these dogs. A lot of them are chronically hypoxemic. And if they're coming in respiratory distress, you're going to see their pulse oximetry decline. And these are measures you can take to increase their oxygen, depending on how stable they present to your clinic. There is a profound number of drugs you can utilize for this condition to try and alleviate these dogs' clinical signs, whether it be in preparation for surgery or whether it be as primary management of these cases. So, for example, steroids is very commonly used. I actually will use steroids perioperatively to help decrease the swelling of the airway, more so in those cases that do have bad laryngeal collapse and a lot of laryngeal edema. That's a concern for me, obviously. And if you're going to operate in the oral cavity, you're probably going to make that inflammation worse. So it's nice to have steroids on board to help decrease that swelling and inflammation there to stabilize the pet. But of course, there are downfalls of steroids that we all recognize. And depending on when you graduated school and who your mentors were, you either think steroids are a saving grace or the devil, depending on the era. It tends to go in out of favor in the vet field. But steroids are both injectable and oral. Then you've got a variety of sedatives. I'm showing acepromazine and propofol here, but there's newer drugs, of course, out there that you can use for sedation. And we will use sedation to keep these dogs under control in their natural environment at home if you're medically managing them as your primary mode of therapy, or if they're coming in a respiratory crisis and you need to capture that airway, you want to sedate them and be able to intubate them safely so you can control their airway, get their temperature down, get their blood pressure up, get them more stabilized for surgery while you're trying to also simultaneously diagnose the condition, because acute respiratory compromise and a brachycephalic can happen for other reasons, not just brachycephalic airway syndrome. But the point is sedation, get control of that airway, and then go from there. And so then a picture there of the pug, it's intubated. The context may be that the dog came in unstable, in shock, and we had to intubate and what have you, or this dog's getting prepped ready for surgery. And sometimes you have to have them under sedation, intubated, even on either manual ventilation or ventilator, because they're not recovering from surgery that well because of all that swelling and inflammation. So some dogs are in the ICU, lateral or sternal recumbency being monitored 24/7 on a CRI of some kind of sedative and on oxygen. Now, this slide is to remind me to talk about various tips and tricks you can use for these dogs, because if you think about it, you're performing an upper airway surgery on dogs that may have also gastrointestinal disease. They also may come in a little bit less stable to you. And so how can you minimize complications? So for example, Cerenia, it's obviously a fantastic drug for many reasons. Lots of us are using it as a pre-medication or part of our pre-medication protocol. I like Cerenia to try and minimize postoperative nausea and regurgitation or vomiting in these dogs. It's great for that. Metoclopramide, especially if the dog was not fasted before surgery. Let's say you have to perform surgery in an emergency setting, and on the radiographs you see the stomach's full of food. A dose of Reglan at the time of admittance or at intubation will hopefully help pass that food along to minimize postoperative aspiration, bronchopneumonia. But I'll actually even keep some of these dogs on a CRI of metoclopramide to help with gastric motility and gastrointestinal motility to minimize any of that esophageal reflux, esophagitis, regurg, vomiting. So I think it's a great drug to use. I'm not sure. I had to check recently, but last I heard there wasn't much difference in terms of giving TID boluses of Reglan versus a CRI, but that There may be new literature out there that I'm just not aware of regarding that. But regardless, I tend to give them an injection of Reglan as part of their pre-med, and then if I want to, if I'm really concerned, a CRI of Reglan intra-op and post-op. The reason for the antibiotics there, Convenia and Simple Step, these procedures are considered, they're not sterile procedures. You're working in the airway and the nasal cavity, or the nares, so there's not much for sterility there. I typically don't put them on antibiotics. However, if for some reason I'm going to, let's say perhaps I'm worried there may be early bronchopneumonia, or maybe they have some other comorbidity, they've got bad skin from chronic allergies or something like that. I like Convenia, even though it may not be marketed necessarily for what I'm using it for, but it's a way to bypass the gastrointestinal tract and still provide some kind of antimicrobial coverage. It'll last 10 to 14 days. So I'm a fan of that drug, especially for a lot of airway diseases, not just brachycephalic, but like clapping trachea, tracheal stents, things like that, where I'm trying to minimize oral drugs. Or if I want something a bit on the stronger side, Simple cefpodoxime is really good because it is a once-a-day drug. So anything I can do to minimize these dogs vomiting or regurgitating, having nausea post-op is really cool. If I feel that they need antibiotic coverage. Most of these dogs don't. If there's no real indication for it, then there's no need for it. But just to give you some thoughts of yes, of course, something like Clavamox or Baytril will be better. And if you have obvious bronchopneumonia, you're going to get your big gun antibiotics out. But for the cases where you're sort of looking for coverage of any kind of infection, then these are things to consider as well. And then if your facility has access to performing a temporary tracheostomy, this is a way that, let's say you have a dog with really bad laryngeal collapse, you can't even intubate them, but you need to capture that airway. This is a fairly straightforward procedure. If anybody wanted to look into this further, you can perform it in your practice. Simply, any surgical textbook will have how to do this, and then perhaps if you have access to cadavers, you can then practice this procedure. And this is really useful in case of an emergency for a temporary tracheostomy, not a permanent one, but a temporary one. You need to have the equipment for it and be comfortable with the procedure itself. But it is one way of bypassing the upper airway, so you can intubate these dogs to help with stabilization. Now surgery. There are many general practitioners that perform these surgeries, which is great. It can be done in your clinic, especially with practice, of course, on cadavers or on younger, healthier dogs that are not so critical. But surgery is the treatment of choice, especially for those dogs that just have chronic airway disease, secondary GI issues, are constantly going through a crisis, what have you. The stenotic nares procedure is aimed at providing a cosmetic symmetrical opening of the nares. So you can see in the picture there, before and after, it's a nice opening. There are, in that drawing up top, there are a variety of different techniques you can use. Everybody's got their own opinions on how to perform the wedges, and a lot of veterinarians have their own modified techniques of these. It's whatever works to open up that airway and try to provide some cosmetics to it as well. You want them to be symmetric and nice looking, but more importantly, you want functionality to be there. And so what ends up happening typically is, at least when my hands, I end up repairing usually the right side first because I'm right-handed. I go to repair the left side, and the left side looks way better than the right. And then I'll go back and redo the right side. I'll open it a little bit further. So don't be afraid to kind of modify it as you see fit. There is some art to this, to the nasal surgery, but that's what you're looking for. I typically am going to have an external recumbency. So in that close-up picture of the dog with the sutures in the nares intubated, that's typically the position that I'm going to have them in. And then when I'm ready to move on to the next stage for the elongated soft palate and any other laryngeal issues, I will then have them positioned in that central picture, the 2 IV poles or whatever, with the cling that's keeping their airway open, so that you can start operating in their airway. But nares surgery is paramount, especially if you catch these dogs when the stenotic nares is all they seem to have. If they haven't progressed yet to the point where they've got laryngeal disease, palate disease, etc., it's great. It's great. And there is a study that shows that repairing these dogs at a younger age can prevent them from having other issues down the run, because it is obviously a primary condition. It all starts with stenotic nares typically. And so if we were able to catch these dogs earlier, now how early, I don't really know. There are vets out there that perform this pretty young. It'd be great if you can combine this procedure with their spay or their neuter. That would be awesome, because they're already under anesthesia anyway. But I don't have a minimum age yet, but hopefully in the future we'll see more studies looking into that, because that'll prevent a lot of issues down the road. The next procedure typically is going to be elongated soft palate resection. So in that one drawing, you can see that they're performing this with suturing it along as they're transecting that palate. And then on the very bottom drawing there is trying to show you kind of where your focus is. So as you're looking at the palatopharyngeal arch and where the tip of the epiglottis sits, you want the palate, after you're done repairing it, to be almost in contact right at the tip of that epiglottis. That's what you're looking for. If you have to err on the side of making the palate too long or too short, go for too long. You'd rather have it be too long with a little bit of noisy respirations post-op than too short, and now you're dealing with chronic nasal reflux, regurgitation, constant pneumonia. You can't fix that. You can always make the palate. You can only shorten the palate more if you need to, but you can't really make it long again. So you want to practice on cadavers with this procedure. I have up there, and the other picture is a ligature, which I absolutely love. This thing has spoiled me. The ligature is a very powerful bipolar sealing device meant for vascular pedicles. However, they make a small enough size that I can use it on palates as well, and it avoids the blood and the swelling that's commonly associated with the more old school methods of transecting and suturing at the same time. I love ligature. That being said, it's an expensive device and it's not made for every single palate. Some palates are so thick, you just can't get through with the ligature. But if you're able to, my complication rate from my experience has gone down dramatically with the postoperative swelling when I can use ligature. And by the way, just to specify something here, when you position these dogs, so the central picture there, you're ready to perform your palate surgery, keep in mind a few things. The endotracheal tube, tongue retraction, how open or closed the mouth is, what are you doing with the laryngoscope in there? All that's going to modify the positioning of where the palate is sitting relative to the epiglottis. It's going to be dynamic. And so if you have too much stuff in the oral cavity and you're measuring where you're going to transect this palate based on that, well, you may have an inaccurate estimation. So what you want to do with these dogs ideally is when you're planning on where you're going to cut their palate, you want to ideally have their head and their oral cavity in as much neutral position as possible, so you can see where the natural palate is trying to lie, and then you can plan your cut that way. So I will frequently have somebody just prying the mouth open with their hands, just so much so I can see. I don't have the tongue retracted. I have it in normal position. I actually extubate them temporarily, and then I look at the palate and see where it's sitting and try to plan my cut. And then after I'm pretty satisfied with where I'm going to cut, I either can perform the surgery right then and there because it's really fast if using ligature, or reintubate them, open the mouth back up, and then I can make my cut. So keep that in mind. You're going to deform the anatomical positions of all these structures if you have the mouth open, tongue retracted, intubated, gauze. It's going to mess up your judgment of where to cut these dogs. So there's an art to this. That's the point. Keep in mind all these factors and try to not cut too short. Err on the side of making it too long if you need to. But that's the procedure there. The everted saccules, I've lessened my desire to transect these. They are a secondary change. We're not even sure whether or not they contribute that substantially to increase airway resistance, and they are quite dynamic. In fact, I've had cases where they're everted during the surgery, and then once I repair the nares and the palate, the saccules are gone. They're no longer everted. So whether or not you want to remove them using cautery or using medicine bombs, like in that picture there. The other picture is showing ligature, a removal of the tonsils, which is how I perform them, so bipolar cautery. But the point is, whether or not it's worth removing them, I'm not really sure. It's a judgment call. If I can err on the side of leaving them in, especially if I notice that they've reduced back into their crevices, then I won't remove them, because theoretically, if they're a secondary condition and I've repaired the nares and the palate, then hopefully these will not evert. And even if they do, they may contribute so minimally to their airway resistance that it may not matter. This picture is only to show that there are what I would consider salvage procedures for other conditions that I normally would consider irreparable. So hypoplastic trachea and laryngeal collapse. Those are two factors that are considered largely irreparable. So for example, on the radiograph there, lateral cervical radiograph, you can see a tracheal stent being placed. Would that help hypoplastic trachea dogs? Maybe, maybe not. I don't know, but I've seen it done before for those cases where surgery went great. There's no other abnormalities that we know of in the upper airway, and the dog is still struggling to breathe. And the only thing we can see that's wrong with them is hypoplastic trachea. The discussion with the owner has had tracheal stent, but again, I'm not advocating for this to be done. I'm just saying that if you had a crisis like that, maybe consider it. And then the drawing of the larynx there in the intraoperative view is showing a laryngeal tieback. So a cricoarytenoid lateralization that you normally would use for laryngeal paralysis dogs. Here, you'd be using it not for laryngeal paralysis, unless they happen to have laryngeal paralysis, but these dogs are typically not the demographic that gets affected by LARPAR. But if you have such bad collapsing trachea and you've already repaired everything that's repairable, and the dog is still struggling, and he's got laryngeal collapse, rather, I misspoke, laryngeal collapse, you could consider trying to open up the airway more permanently. Not ideal, because these dogs are already prone to aspiration bronchopneumonia, and this is going to further that risk. But if you're in a crisis, you could consider something like this. Additionally, there are many other laryngeal procedures you can perform. You can have a partial arytenoidectomy as well. You can combine the tieback with a arytenoidectomy. Again, these are all salvage procedures. I'm not advocating these as being a normal mainstream therapy for these dogs. Hopefully, you can get these patients care before they develop laryngeal collapse. But if you're in a crisis and everything else seems to be taken care of, this may be a consideration. It warrants communication with the pet owner to tell them, look, this is somewhat experimental, but we're doing it as a salvage procedure because this dog cannot breathe otherwise. And then, of course, let's not forget, you can consider a permanent tracheostomy tube as opposed to a temporary one that's used just for stabilization. That, of course, is a conversation with pet owners as well, because that's a lifelong, chronic nursing care husbandry issue. And for anybody who's managed a tracheostomy tube, especially in those bulldogs, it can be a nightmare. Mucus plugs and respiratory crises, and it can be a mess. But you have to have the right case, the right pet owner, and understand, again, that's a salvage attempt here. That's not what you're hoping to do. Monitoring, of course, is huge, and we typically will use our own senses to decipher how these dogs are doing, not just pre-op and intra-op, but especially post-op, And we like using devices because they're more objective. So Vet Guardian, for example, phenomenal product that's contactless, and the reason for that is important because some of these dogs are naturally kind of wired emotionally. And when they're also under distress, it creates that vicious cycle. So a device like Vet Guardian provides you with telediagnostics. And with Vet Triage, I'm all about the teles. Anything tele is great for me. And so if we can monitor these patients with objective data from a distance, so minimize interacting with them to stress them out when they're a bit on the fragile side, or if you want something that's continuous, where you can't have a human being realistically continuously monitor these patients, especially if you're talking about measuring things like body temperature, for example, this is a great way to measure these things from afar. And to save your staff from having to babysit a case, they can do other things, and you can count on the alarm system with this product to monitor these patients. So it has always awesome features to it. It's based on thermography, so that's the picture there with all the different heat signals with that dog, and it gives you alerts. It's got updates to it. It's continuous, phenomenal. It's all the parameters that you want. You can have multiple dogs, multiple patients on this being monitored by Vet Guardian at the same time. It sits in front of the cage in whatever fashion you can create. It's got that arm stand to it that you can collapse to an IV, they can attach to an IV pole, and it's adjustable. So it's got benefits for the staff to not make them sit with a case for monitoring purposes. It helps the pet interacting with them, minimizing anxiety. Let's say you have a pet that's in oxygen, for example. Every time you open the oxygen cage, you lose the benefit of oxygen therapy. Well, this allows you to monitor while they're in oxygen without having to open and close that cage. So telediagnostics are certainly the future, and this one is really a state-of-the-art device that if you're performing not just brachycephalic airway surgery, any surgery where you're worried that afterwards the patient is going to be debilitated and require this level of care, this is a great device to consider. So this is how it works. Pretty fancy stuff. This is a close-up of a patient with it, and you can see there on the top screen you can have different animals being monitored simultaneously. So it's a pretty cool device. I could not recommend it more. And you can have it on different devices as well. A lot of the hospitals these days, especially the ones that are playing around with these surgeries and this level of equipment, they're using many different modalities with electronic medical records to monitor these pets. So could not recommend that enough. It's anything you can do to minimize interacting with these pets that are a bit on the fragile side is really worth it. But anything like a post-op hemoabdomen, a GDV, a septic abdomen, all these cases, they can benefit from minimal contact, but still getting continuous monitoring. Post-operative complications. So bronchopneumonia, always a concern for these dogs, especially if you're dealing with that overweight, naturally lazy, older brachycephalic that is just a mess clinically, not just from a brachycephalic standpoint, but it's got a bunch of other conditions, comorbidities, and it's just going to be sedentary after surgery. I want these dogs up and walking. And as long as they can handle it with ventilation, I want them up and walking. Every 2 to 4 hours, 10-minute walk, if not outside because of the heat or it's just too far away, then either carry them outside or have them walk around the ICU or your hospital just to get the airway movement going. If they're just going to lay in their cage, and not move, be sedentary, they're going to be way more prone for aspirating vomit or regurgitation and getting bronchopneumonia. So we want to be cautious of that. Any dog that's having breathing issues post-op, especially when the initial recovery was fine, you worry about pneumonia, especially in combination with other symptoms like nasal discharge and a fever. The gross anatomy picture there is showing a really severe laryngeal collapse. You can see that epiglottis there, which is that crescent shape, and then right above it, the arytenoids are just glued together. I mean, that is severe. And what's also making this worse, all the edema and inflammation surrounding it. So this is a really bad laryngeal collapse in this dog. And then finally in the picture below, an intraoperative view of a tracheostomy, because if they're having breathing issues after surgery, and you're trying to reintubate them, and for some reason you can't because of the postoperative swelling or because of their laryngeal collapse, you want to be able to bypass their airway. So having a conversation with the pet owners about what kind of aftercare may be required may influence your decision as a doctor to cut these dogs, because if you don't have access to overnight monitoring or being able to deal with a postoperative crisis, then it may be a situation where either you don't perform the surgery or you perform the surgery and then transfer them automatically to ER, or you have some systems set up where you can monitor them post-op at your facility 24/7. When you look at the outcome, it's actually largely pretty positive. Improvement is seen up towards 100% of dogs. So even if improvement doesn't mean normalization, right? So as long as they improve, that's pretty good. You have to set the client's expectations. A 6-month-old brachycephalic with just nares and maybe a slightly elongated palate is going to have a way better recovery post-op, meaning resolution of their upper airway sounds, than this 14-year-old obese arthritic, English bulldog that's had this disease for its entire life. The expectation can't be we're going to make this dog a puppy again. The expectation is he will probably get better, and we probably are decreasing his risk of developing other issues downstream, lower airway disease, laryngeal collapse, pneumonia, by doing this procedure, but he will not be a normal dog. He's not going to be a quiet, breathing, normal dog, especially if you live in an area of the world where there's a lot of humidity or heat where you live, and especially if this dog is obese, overweight, it's going to be hard to resolve these issues. So you want to set client expectations. Mortality, 4%. Recovery, 6 months post-op are deemed excellent in 65% of cases, good in 25% of cases. Excellent 1-year recovery, 50%, moderate 48%, poor 2%. Pretty good numbers considering what you're dealing with. Obviously, there's going to be a wide variation in the literature for post-op recovery, because it is certainly going to be different whether or not you're dealing with a younger patient versus an older one with these dogs. So, and then of course, all the comorbidities associated with it. So when you talk about prognosis from the literature, these are the main factors here. So when you have that conversation with pet owners, you can tell them, look, here are the different factors that affect prognosis. Here's where your dog sits in all of these factors. What do you want to do? What are your thoughts? So early surgery, obviously, as we mentioned before many times, if you can intervene with these dogs earlier, stenotic nares, palate, and that's where it ends, much better outcome than dogs that have surgery later on in life when they're more progressive disease. They've got laryngeal edema, cardiac disease, etc. So in line with that, younger dogs have a better prognosis. Younger dogs tend to have better prognoses. They have less comorbidities. They've been dealing with disease for a shorter duration. So young dogs, great. They do much better than older dogs. Laryngeal collapse, of course, this has been shown. The higher the stage of laryngeal collapse, the worse the prognosis. That makes sense. And it ties into younger versus older dogs. It turns into early versus late surgery. Laryngeal collapse is a prognostic factor that you won't be able to tell while the dog is awake. When you're in the exam room with the pet owner and the pet, you have to perform laryngoscopy to figure that out. But laryngeal collapse, of course, is a factor here. The presence of hypoplastic trachea, same thing. You can't tell before you collect radiographs whether or not they have this condition, this abnormality in the trachea, but it is a conversation to be had, especially with the owner that owns an English Bulldog. And then GI disease, huge because it's probably not as well documented as the obvious respiratory stuff. So GI disease, the presence of chronic GI disease in the dogs worsens the prognosis. And we know that to be true from the literature. We're just not 100% sure whether or not every single case is a secondary condition or if it's a separate issue altogether. But if you see it in association with Brachycephalic syndrome, you want to tell the pet owner your dog may need something. And by the way, not need something, may have a worse prognosis. With GI disease in these dogs, besides the Cerenia and the metoclopramide administration, I have no problem putting these dogs that have a chronic history of fluctuating GI disease on chronic antacids. I'll put them on either Pepcid or ideally omeprazole, and I'll start with like a twice a day standard dose, and I'll do that for like a month or a month and a half. And if the pet owner says, things look pretty good, actually hasn't had any GI episodes since surgery, and since he's been on this antacid, then we can start weaning him down. Let's try once a day. Basically find out what the minimal dose of that antacid can be implemented to get the optimal benefit. And if he does great on twice a day, but not on once a day, then this dog should live on twice a day. Now, I'm sure internal medicine doctors may have a different view on that. As a surgeon, that's typically what I'm going to offer to these clients for those dogs that have a history of chronic GI disease. This is not a standard across the board. This is only for those that have a history of this. So keep that in mind too. Try to address all these issues. We don't just want to focus on the airway. If they have GI disease, then we want to contend with that as well. So a few key points here that hopefully we hit home. Client communication is key. And what I mean by that is when you talk about this condition, to not overwhelm this pet owner who's never heard about this disease before, mention it in terms of either primary or secondary disease, or ideally, probably more applicable, repairable versus irreparable. Things I can fix, things I can't fix. So things I can fix are going to be the nares, the elongated soft palate, everted saccule or everted laryngeal saccules. And what I can't fix are the other things. Any nasopharyngeal issues, nasal cavity issues, laryngeal collapse, unless I'm thinking about salvage procedures, hypoplastic trachea, bronchiolar collapse. Those things are largely irreparable. And so the pet owner ought to understand that these things can be found, and it's going to maybe affect how the post-op recovery is. So repairable versus irreparable aspects of this disease. Keep in mind GI disease in these dogs, get a more thorough history, really investigate this, and then keep that in mind when you're trying to prevent bronchopneumonia, pre-op, intra-op, post-op, and then long-term post-op with recovery. And then finally, you're going to tailor the surgical repair to the case, obviously. Not every dog has elongated palate. Not every dog has everted saccules, laryngeal collapse, etc. So you don't want to just automatically have the same procedure across the board. You want to actually diagnose these dogs. That's obviously the ethical way to do this, and also helps instruct the owner as far as what they're dealing with. And that's my talk for Brachycephalic airway syndrome. This is my contact information. That's the QR code for Vet Triage if anybody's interested in partnership. And I can't thank Zomedica enough for sponsoring this event and for providing us with incredible diagnostics that are like VetGuardian that are really, really useful to help improve post-operative care. I think as veterinarians, we tend to somewhat be a bit more lax with post-op care, thinking surgery's done, we're good to go. Really, post-op care can make or break the procedure. And if we can minimize the error of overlooking symptoms, especially in symptoms that are more hidden, like these dogs can be, devices like that are really useful. So check them out as well. And I'm happy to entertain any questions that you may have.